approximate a number?
Well, I believe that the manufacturer shows a chart where they say that if you have a single sedative level of propofol, then you would expect it to go down and the person would wake up within about 5 minutes.
About 5 minutes. Now, assuming that you did infuse this 25 milligrams over 3 to 5 minutes to produce 5 minutes of sleep, how long would it be before the propofol was entirely out of the person's bloodstream?
Objection, if he knows.
Can you estimate? How long would the objection at this point? If you know.
I don't think I could estimate. I mean, it depends kind of on what you mean by entirely out,
Okay.
because it doesn't go in a straight line, really.
Well, you would agree that the propofol would have no effect after 10 or 15 minutes, would it?
That's true.
That's true?
Yes.
So if it was infused that way, between 10:40 and 10:50, latest being 10:50 at the end of the infusion, the propofol would have absolutely no effect at 11:05 and on, would it?
That's correct if the infusion were stopped at that point.
Now, what happens if rather than infusing it over 3 to 5 minutes, you jam it all at once? 25 milligrams.
Well, the result of that is that you would have a locally high concentration of propofol. That is, it wouldn't have enough time to wash downstream. And so when that locally high concentration reaches the brain, there would be a greater risk of cardiorespiratory arrest.
Okay, so is that pretty much why most IV drugs are administered fairly slowly, aren't they?
Yes.
Because by administering it kind of slowly, you achieve, that's kind of a way of distributing it more evenly through the bloodstream, isn't it?
Yes.
And if you just come in with a big chunk of it all at once, it can cause problems, can it?
That's possible, yes.
So the medical way to administer propofol, as with most other IV drugs, is to slowly infuse it, correct?
Yes.
Now, if a person is slowly infusing propofol, you can see the effects, can't you?
Yes.
And you can control the effects, can't you?
Objection, since that's not evidence that you're in the room.
The objection is sustained. I think you're going to have to re-ask the question, please.
Well, if a person is slowly infusing propofol with a syringe, would you admit that he would have to be in the same room?
Yes.
And that person is slowly administering that propofol with a syringe would see the effects, wouldn't it?
Yes.
And would you also agree that in the event there was an adverse effect from the administration of propofol through that syringe, you would see it right away, wouldn't you?
Well, I believe you would eventually see it. I'm not sure you would see it instantly.
Well, if a person all of a sudden stopped breathing, you should be able to detect that, shouldn't you?
Yes.
And if while you're administering there, you've got a pulse oximeter, you're going to basically see if there's any changes in the oxygenation or the pulse of the individual, aren't you?
Yes.
If the heart stops, you should be able to detect that right away, correct?
Yes.
Or if the breathing stops, you're going to detect it right away.
That's correct.
And if you sit there and after you've infused that and you watch that patient for 15 minutes or 20 minutes, I'm talking about the way we've just been discussing, a slow infusion of 25 milligrams, and you sit there and watch that patient for 15 or 20 minutes. If something goes wrong, it's probably not caused by propofol, is it?
I'm not sure I understand.
Okay, hypothetically, you're infusing 25 milligrams of propofol over a 3 to 5 minute period of time. Person goes to sleep. And you continue to watch for another 15 or 20 minutes. After that 15 or 20 minute period of time, if something goes wrong, it's probably not caused by propofol, is it?
Objection, improper, hypothetical, assumes facts not in evidence.
What is being assumed that's not in evidence?
Well, the witness, number one, has testified that the individual would already be awake. Secondly, it's not including the additional benzodiazepines.
I'm sustaining the objection. I don't know if it's a complete hypothetical. Sustained.
Well, if a person, after you've infused 25 milligrams of propofol, slowly over a 3 to 5 minute period of time, and they fall asleep, you would expect propofol to keep them asleep for probably 5 minutes. Is that correct?
Something like that, yes.
And then we go beyond that 5 minutes, and they continue to sleep with normal respiration and normal pulse. You would then assume that they're sleeping for some other reason, wouldn't you?
Well, that would be correct because if you didn't give more propofol, the person would wake up.
Yeah. And so there's other common causes of sleep, isn't there? Other than medication.
Yes,
Probably the most common cause would be fatigue.
that's correct.
If the person was very tired and went to sleep, sleep induced by propofol, and continued to sleep, it's entirely reasonable to conclude that he's sleeping because he's tired. Wouldn't that be correct?
That would be a possibility.
Okay. Now, I want to move on. Well, I'd like to get a couple definitions from you. Therapeutic level. In your job as a coroner and in analyzing toxicology data, do you ever make reference to the term therapeutic level?
Yes.
What is the therapeutic level?
That's the drug concentration where you would expect the drug to have its intended effect.
Okay. Propofol. Do you have a guideline that you use to determine a therapeutic level of propofol?
Yes.
What is the guideline that you use?
Well, depending on what you're trying to do, if the propofol is being used for major surgery, you would expect it to be somewhere around 4 micrograms per milliliter. If it were being used for lighter sedation, then you would expect a smaller amount.
How small amount?
Possibly half of that.
Okay, so 2 micrograms per milliliter. Correct?
Could be therapeutic, yes.
So what is therapeutic, the correct therapeutic level would be dependent upon the intended use that you want to make of the propofol.
Yes, in part.
So if you wanted to put a person under such that you could operate, do a hip replacement or open their chest, you'd need a level above 4 micrograms per milliliter, correct?
Yes.
But if you just wanted to put them to sleep for something that wasn't quite as or do a procedure that's not as quite as painful, you might go all the way down to 2 micrograms per milliliter, correct?
Yes.
Now, in this particular case, there was a determination that Mr. Jackson had 2.6 micrograms per milliliter in his femoral blood. Is that correct?
Yes.
And femoral blood is the standard that the coroners find to be the significant level, isn't it?
Yes.
Because, and we'll talk about this in a little while, but femoral blood is also called peripheral blood.
Yes.
And in addition to the peripheral blood, which you can get from the femoral vein, you got central blood, correct?
That's correct.
But when it comes to measuring and doing a postmortem measurement, your office is going to rely more on the peripheral blood rather than the central blood, isn't it?
Yes.
And why is that?
The central blood, which comes from near the heart, is more prone to postmortem effects, like, for instance, there might be postmortem diffusion from the lungs, the stomach, the liver, things like that. But the femoral blood, which is further out, and it isn't really near any large organ, has less of that problem.
And this postmortem redistribution, so to speak, is more common in, say, the heart blood, correct?
Yes.
Whereas the femoral blood is kind of the gold standard that coroners use when they do a post-mortem examination in an attempt to predict ante-mortem levels. Did I say that right?
Well, we can tell you what the postmortem levels are now. They may have different relations to the antemortem levels. That's
Okay.
sort
Well,
of complicated.
my question was,
I'm sorry, it's what?
It's sort of complicated to relate postmortem to antemortem.
Okay, we have various mics here, and for the in-court microphone, I'm having some problems hearing. So if you could speak up a little louder, I think it'll help us out. Thank you.
when you're doing a post-mortem examination, now that's an examination, a toxicological examination after death, correct?
Yes.
When you're doing that kind of an examination, from that you're trying to approximate what the antemortem levels were, correct?
Yes.
And so when you do that,